I'm Mayor B. Davidson, a physician who runs the diabetes program at the Martin Luther King Outpatient Center. Well, there are two kinds of diabetes in general. One is called type 1, and those patients have to have insulin right from the get-go, from the beginning. In type 2 diabetes, we can start with just one pill, and that's very effective for a while. But as time goes on, the patient's ability to make insulin goes down, so then we have to go to 2 pills and 3 pills and sometimes another injectable but non-insulin medication. But eventually, the insulin secretion by the pancreas is so little that many patients will need insulin, and currently about 30% of patients are taking insulin. Insulin has to be given by injection, and so you take it usually before meals or at bedtime, and there's various ways of giving it and various regimens that we use. But if a patient needs insulin, usually one injection will work in the beginning, but after that often 2 or more injections are necessary. Insulin is life-saving for type 1 diabetic patients acutely. If they don't have insulin, within several days they will get into big trouble, have to go in the hospital, and if they don't get to the hospital, they can die. In type 2 diabetes, if patients need insulin but don't take it, it's a much slower process. Often they will go for many months to years with just high blood glucoses, and this leads to the complications of diabetes, which can be devastating. On the other hand, if they really need insulin, within several weeks to months they can get such high blood sugars that they have to go into a hospital because eventually they'll go into coma if they don't get the insulin. The symptoms, if people who have type 1 diabetes don't get insulin, is they become very thirsty, they urinate quite a lot, they become very lethargic, that is, they can't think straight, and they actually will go into coma, and too much acid will build up in their body, and if they don't get the insulin, they'll die. In type 2 diabetes, it's a more gradual process. The sugars get very high. Patients again get thirsty and urinate quite a bit, and very gradually will have difficulty thinking and can go into a coma, but this takes usually weeks to several months. In type 1 diabetes, it will occur within several days. The problem at the moment for some patients is that the costs of insulin are going up, and so much so that some patients can't afford it, and what we're finding is that they will take less insulin than we recommend in order to stretch out the length of time that they will have the insulin. In LA, where I practice, there is actually a black market for insulin, in that patients will get insulin prescribed and they will pick it up at a pharmacy, but then will sell it on the street for even more money than they bought it for, and then go and get a cheaper brand of insulin that they can get at Walmart. So the problem is that the wholesale cost of insulin has increased tremendously in the past 4, 5, 6 years. It's gone up 30% between 2011 and 2013, and in some cases 40 and 50, and in one case 60%. And again, between 2013 and 2015, it's gone up another 30 to 60%. And this has been a tremendous problem for a lot of patients. And when the wholesale cost of insulin goes up, then that cost gets translated to the patient, and the co-pays they have to fork over also goes up. And a lot of patients are having trouble, at least in our population, affording it, especially if they don't have very good insurance. Well, the increased price of insulin is paid for by various sources. If there's insurance, then the insurance company has to pay the extra amount. But there's often a copay, so the patient has to pay a certain percentage, a small percentage, but a certain percentage of the drug, so that the higher the cost of the drug, the more that they have to pay as a copay. And if the patients don't have insurance, and because they don't get enough insulin, and they go to the emergency rooms, they're taken care of, and the hospital sort of eats the bill, but that, of course, the taxpayer has to pay it because there's not money from insurance to cover their costs. Well, Proposition 61, as I understand it, and I'm certainly no expert, is that the cost of drugs in California could not be more than what the VA system pays for it. And the VA system, as I understand it, has a contract that they get a 24% decrease in the cost of medication compared to the rest of the organizations that negotiate with the pharmaceutical companies. And so if it passes, then supposedly the cost of the drugs that are paid for in California will go down because they will have to be no more than what the VA pays for. So I've often been asked whether diet and exercise alone can treat or cure diabetes. And in the beginning, it can be very effective. Now, the reason that many people get diabetes is because the amount of insulin they produce in their body is not enough to overcome the resistance to insulin that the body has. And as we get more and more obese, there's more and more resistance to insulin, and as we exercise less and less, there's more resistance. So when a person with type 2 diabetes is originally diagnosed, if they can lose the weight and if they can exercise moderately, there is a good chance that the glucoses, which are high in diabetes, will go down toward normal and maybe even normal. However, the ability of the pancreas to secrete insulin goes down progressively over time, so that eventually just diet and exercise will most often not work, and people then will need some medication. One of the complications of diabetes is kidney damage, and as the kidney becomes less and less effective, then the final treatment of that is dialysis. And unfortunately, 50% of all the patients on dialysis have diabetes, and the sad fact is that that was unnecessary. That if the blood glucoses can be controlled toward normal, then you don't have kidney damage and you don't have to go into dialysis. But unfortunately, and this will sound silly maybe, unfortunately diabetes doesn't hurt, so that there is little motivation for people to really take care of their disease, and they have little symptoms even though year in and year out they have very high blood glucoses, and those blood glucoses are what leads to the kidney damage, which eventually leads many patients unfortunately to have to go into dialysis. I'm sometimes asked, what can people do to try to control the rising cost of these drugs? Unfortunately, individuals can't do very much about it. The cost of the drugs are arrived at by negotiations between the pharmaceutical companies and the organizations that need to use the drugs. The VA has lower prices because they're large organizations and they can negotiate from a relatively strong point of view. Unfortunately, Medicare, for instance, cannot. Congress has not allowed Medicare to negotiate with the pharmaceutical companies. An analogy might be looking at foreign governments. The cost of drugs in other countries is much less than the United States, and one of the reasons is that the government entities negotiate with the pharmaceutical companies for the prices, and that's one of the reasons why the prices are less in foreign countries than they are in the United States. The drugs in the United States are much higher than drugs in general in other countries. For instance, a vial of this insulin in 2011, the wholesale cost was about $66, and now it's up to over $150.